Dr. Hikmet, for this introduction. I'm sure a lot of you had questioned how come a surgeon talking about this issue. Believe me, I'd rather talk about laparoscopic liver resection and colon resection rather than this project. It's made my hand full for the last several months. First, before I proceed, I'd rather to really thank the member of our subcommittee, Sausan, Anwar, Farid, Dana, and Samir. They have contributed a lot to this project, and we met several times, and they're really the real heroes behind what we're doing here, and your work is greatly appreciated, Sausan, Anwar, and Dana. Let's just go with some background information, and basically catheter-related infections in general. Some people like to call it health-associated infections or device-associated infections. It's really results in a significant mortality and morbidity and results in a very long hospital stay. For example, in the United States, the cost of a single Clabsi, which is, again, central line-associated bloodstream infection, is almost $36,000. If we're going to take, assume that our expenses here is 10% of what the United States expenses is, that means almost $3,600, which is too much for our limited income. It's responsible for more than 30,000 annual deaths in the United States. This is a huge burden for something that can be prevented. This is the issue. This can be prevented. It's not, we can't treat it. We know we can't treat it, but again, we can prevent this with simple interventions per evidence-based medicine. We have several types of catheters. This could be defined or classified according to the vessel that occupies, venous, arterial, peripheral or central, lifespan, short-term versus long-term, site of insertion, femoral, subclavian, jugular, or PICC line. We're all familiar with these catheters, and I'm sure our specific patient populations resulted in us, almost every single one of us, have dealt with these catheters at one point in his career. So there are a lot of catheters, a lot of classifications, but in general, we're going to talk about central lines where the vessel is ended, the tip of the vessel is ended in a central vein. Let's go to the definitions, and basically we're going to start on take it step by step. Well, if you go to the cdc.gov, you'll see these multiple definitions. First, we have the bloodstream infection or the primary bloodstream infection, BSI, which is a laboratory confirmed bloodstream infections that are not secondary to an infection at another body site. Now, there are certain criteria how you can define LCBSI. It's there on the CDC website. The scope of this lecture is not to go through these definitions in details, is to talk about preventive strategies to decrease these issues. We have two main definitions that actually, if you're going to concentrate, they're very, very confusing and in the literature, they've been used interchangeably, although they're very different. We have the Clabsi, which is catheter-related BSI, or catheter-related bloodstream infection, and we have the Clabsi, which is our talk today, which is central line-associated BSI or bloodstream infection. Now, just to tell you how confusing is this issue or the definition, this is a systematic review of 190 articles that looked at the issue of central venous catheter infections in oncology patients. They identified, just based on this 190 articles, more than 26 definitions. Only 14 of them used the CDC definitions, the ones that were published lately. Despite using the referencing to the CDC definitions, the actual definition that they used was different. So the definition is essential, and I can tell you our infectious control committee, led by Dr. Osama H and Sausan, is doing a great job to follow the exact definitions by CDC and the most updated one from April this year. In terms of Clabsi, is a clinical definition that requires a specific laboratory testing, blood cultures, that identify the catheter as a source of the infection. So you have to have a culture of the tip of the central line that is positive to call this Clabsi. This is not routinely used, or this is not what we use for surveillance purposes or for data reporting purposes, because a lot of times we think that we have a catheter-related bloodstream infection, but we don't take the catheter out. Patient has difficult access, he's unstable, he needs the central line. So this definition is very specific, and it needs specific criteria. And there's a lot of laboratory labs across the world. They don't use quantitative blood test cultures define its Clabsi versus Clabsi. On the other hand, Clabsi is a primary BSI, so it's a bloodstream infection in a patient that had a central line within the 48 hours period before the development of the BSI. So this is the most commonly used to report data and for surveillance purposes. But just keep in mind, sometimes the patient would have a bloodstream infection that is related to something else that we did not discover ourselves. So in general, it's acceptable that this Clabsi definition may overestimate the true incidence of a Clabsi. But again, for reporting data and for surveillance purposes, everybody use Clabsi, not Clabsi. The most updated definition from April 2013 CDC website, they made some adjustments. Again, our infectious control committee following these updates on daily basis, and they're very, very meticulous when they define the Clabsi versus something else. We know that pathogens, this is from the United States, most commonly coag-negative staph. I don't have the data for our center. I know it's there, but I didn't have access to it. Staph aureus, E. coli, Candida, and gram-negative bacilli in almost 20% of these patients. Now, how does the central line get contaminated or infected? We have 4 major routes. We have the migration of the skin organism at the insertion site. Basically, at the time of insertion, the organism transferred through the subcutaneous tunnel or the subcutaneous pathway of the catheter and ended up in the tip. This is the most common way of contamination. We have the direct contamination from the daily use of the central line by contaminated hubs. And we have the infusate contamination, which is very rare, and rarely the hematogenous spread from infections elsewhere. If you see, everybody of us can contribute to this pathogenesis. Those who insert, those who maintain, those who use, and even the pharmacy who prepare the infusate. So we are all can participate at some point or at least in a central line infection. So the job, it's not about the one who just insert the central line or the one who care about the central line or the one who, it's our job all to prevent this issue that is, again, it can result in death and cost us a lot. There's a lot of factors that contribute to central line infection. This is evidence-based, and we know from multiple done studies that elective administration results in a lower infection compared to emergency. The one who is specialized in central line insertion has a much lower rate than the one who puts central line occasionally. We know subclavian has a lower rate compared to internal jugular and femoral. And you just have to weigh the risk and benefits for the complication. If you're not comfortable putting central line in the subclavian with the risk of pneumothorax, I think you have to do internal jugular. And we know for pediatrics, we use femoral because of the other, for other logistic issues. In terms of skin antisepsis, we know, and it's well done and it's well documented, multiple trials, that 2% chlorhexidine with 70% alcohol results in the lowest rate of infection. So using bovidine in a patient who does not have allergy to chlorhexidine is not justified at all. Single lumen has lower incidence than multiple lumen. Unfortunately, we have only multiple lumen catheters here at KHCC. The longer the duration of the catheter, especially for temporary, the higher the risk of infection. And very important, the barrier precautions. And we're going to talk about it in details. If you use submaximal barriers, the risk of infection is much higher compared to maximal barriers. This is how we calculate Clabsi. Again, Sausan and Dr. Osama H and the Infectious Control Committee, they're very meticulous about these calculations. We're not going to talk about it in details, but it's a number of central line or Clabsi over the number of central line days. There's certain formulas how to calculate that, multiplied by 1,000. This is how we reported Clabsi per 100,000 central line days. Let's look at the Clabsi rates. First, let's just look at the Clabsi rates across the world, especially in the United States. This is called National Healthcare Safety Network. It's a network established following CDC, and basically they get data from almost 3,800 hospitals in the United States. So it's a huge amount of data that they are kind of enforcing hospitals who are participating to report this data every quarter on all device-associated infections, COTI, central line, ventilator-associated events. All these events are published on annual basis. This is the most recent publication in 2013 for the 2011 data. Again, different type of hospitals, teaching versus non-teaching. This is their central line, or this is Clabsi rate in their ICU and surgical and medical floors. You'll see the highest rate is 3.7 in burn patients. And we all know that burn patients are very unique and very susceptible to having central line infection because of the loss of a skin barrier. But other than the 3.7, the majority is below 2, except for, with 1, and even like approaching 1 and below 1, except for the pediatric medical and surgical units, has a 1.8 ratio. This is the mean, and this is the median. Again, highest in burn. I think it's justified, but the majority is below than 1. This is from more than 3,800 hospitals. Now, people will say, well, this does not apply to us because we are a cancer center. Well, they have data on oncology units in general. This is data specific for oncology patients. And you see there for permanent catheters, the rate range from 1.6 to 2.4. Again, BMT or a hematopoietic stem cell transplant has the highest rate. But it's around 2 and even less than 2. And for temporary catheter, it's the same issue. It's around 2 for cancer patients in the United States. And you look at the median, it's below than 2 persistently. So what's the story here at King Hussein Cancer Center? And if Dr. Hikmet had showed you our results up to the third quarter of 2012. We have now data on the fourth quarter. It's around 6, okay? 6 per 1,000 catheter days. And I think if we're going to compare us to the United States, we are at least 2 to 3 times higher. If we're going to accept that in oncology patients, the rate is around 2 or even sometimes less than 2. If we're going to go in details, where is our problem? I'm not going to go in specific details, but basically if you look at our rate of permanent catheters, that means Port, Perm, and Hickman, it's around 5 to 5.4 compared to 2, so at least 2 times higher than the average or the expected. But if you look at temporary catheters, this is adult temporary catheters, 8. That means 4 times above the average. And this is pediatric temporary catheters, 16. So we have an issue here in temporary catheters, and that's why we have established this project. So we have a problem. What we have done, the first thing, if you have a problem, you go and find what are the causes of this problem, or where is the issue happening. What we found, we have a problem in awareness of the problem. Basically, most people does not recognize or realize that we have a high Clabsi rate compared to other centers. Now, I'm not comparing ourselves to hospitals in Jordan because I think we are the only one who have such data, and we are the only one maybe who are really care about quality of care and patient safety. I know other hospitals have some projects, but in terms of supplies and in terms of resources, I think we are very well equipped to handle this issue and have such project. We have a problem in the knowledge of the best practice guidelines for the insertion, and we're going to talk about it in details. We have a huge gap in supplies. And finally, we don't have a policy for a comprehensive policy that tackles this issue from all aspects where people can go and check every time they have the issue. Excuse me. Okay. So this is central line being inserted at KHCC. Basically, you see this drape. This is what we provide our physicians to insert central lines. A small drape that has a hole in the middle, does not cover the whole patient, and basically this is very against the maximal precaution that we talked about it. If you look, they provide another drape to cover the tray, partially covering the tray for insertion. You see this is a trash bag and this is a trash bag, and this is a major break in the maximal prior precautions. Again, this is where you go back and forth in using the instruments, and the trash bag is there. So we have an issue in the best practice guidelines and supplies. This is the central line insertion tray. And if you look for the whole tray, you won't find chlorhexidine as part of the stocks. Basically, they have bovidine. And again, we have clearly identified that bovidine is not ideal anymore because it's submaximal compared to chlorhexidine. In terms of drapes, 1 or 2 towels and minimal, and this is a minimal drape. So basically, we're not providing the physician who's inserting central lines with adequate supplies to follow the best practice guidelines. So we went and looked at the guidelines for CDC, and it's not only CDC who is interested in this. Also, Joint Commission is interested in this. This is their most recent publication, December of 2012. A global challenge and a global perspective. It's led by an Egyptian infectious disease specialist. But again, I think next time we're being evaluated by a Joint Commission, I'm sure we are going to look at this issue very carefully. So let's just look at the story of Clabsi prevention. Very nice story, led by a famous physician from Johns Hopkins called Peter Pronovost. Peter Pronovost had established a project at Hopkins ICU to prevent infections. Looked at the best practice based on evidence-based, and just bundled everything in a very strict way, and they were able to achieve a 0% Clabsi in Hopkins. Now, people were so skeptical about his results. Basically, this is Hopkins, they can do whatever they want. Well, he did not stop there. He took his project to more than 100 ICUs in Michigan. He contracted with multiple hospitals in Michigan, and the same project, the same bundle was taken there. Again, more than 100 ICU in Michigan. 5 simple intervention: hand hygiene, maximal barriers, chlorhexidine disinfection, avoiding femoral sites, and removing the central line when it's not needed anymore. 5 simple intervention. To assure the implementation of this 5 simple intervention, he contracted with the CEOs of these hospitals. So it's not at the basics of the nurses or physicians who deal with the central line. The CEOs has to interfere first. He made sure that central venous catheter trays that has all the necessary supplies are available for insertion. This is number 1. There's a checklist to ensure adherence to proper practices. He empowered nurses to stop procedure in non-emergent situation if evidence-based practices were not being followed. And there were a policy about prompt removal of central lines identified during daily patient rounds. And finally, he had a buy-in from chief executive officers of all participating hospitals that all the supplies will be in there, including chlorhexidine gluconate solutions, before the initiation of these studies. What are the results? Just look carefully here. This is where this started. A median rate of 2.7. Within 3 months of implementation, it went down to 0. Now, the median was 7.7, and after implementation, it's down to 1.3. The thing is, it's not only within 3 months it dropped it. The drop was sustained over an 18-month period. This was true for all types of hospitals who participated, regardless of whether teaching versus non-teaching, regardless of the bed numbers. So basically, 5 simple intervention dropped the rate down to 0 at more than 100 ICUs. Well, he did not stop there. Took it to Connecticut. Same almost experience. The baseline rate 1.8 down to 1.1 with a median of 0. So again, same experience. England took the same experience called Michigan, a 2-year STEP interventional program. Significant reduction in their Clabsi rate with this simple intervention. He did not stop there. He looked into, people were so skeptical about his results. So he did a prospective randomized trials, had more than 45 ICUs. He classified these ICUs to an intervention group versus no intervention group. The baseline Clabsi at the intervention group was 4.48, and the baseline for the control group was 2.7. After the implementation of his 5 simple intervention, the Clabsi rate dropped from 4.48 in the intervention group down to 1.33. But for the control group, it stayed almost the same. So this is, can tell you if you apply this 5 simple intervention, you can reduce the rate significantly. Now it's turning into a global issue, as we said. There's multiple international projects, one from the Institute for Healthcare Improvement, 5 Million Lives campaign. We have the Canadian Patient Safety Institute, Safer Healthcare Now. And we have the WHO Bacteremia Zero project. So it's really like a global problems with a lot of people now becoming aware that this is a preventable cause of mortality. So it's very important for all us to cooperate in preventing that. An infectious disease specialist called Victor Rosenthal, he was very smart. He took the same bundles that Peter Pronovost applied in the United States, and he started collaborating with people across the world on that. He established something called INICC, International Nosocomial Infectious Control Consortium. And the same bundle. It's not science. It's not science fiction. It's not rocket. It's just same hand hygiene, maximal barriers, removal when it's not needed, and chlorhexidine. So he came up with these publications of Clabsi in 15 developing countries from 2010. In his name called Victor Rosenthal. He provides his consultations with a very high fees to hospitals who are interested to collaborate with them. 14 hospitals were in Turkey and 1 in Lebanon. Basically, again, it's simple 5 intervention, but he was able with this intervention to drop the rate from 16. Luckily, we're not at 16 at this time, to 7.4, with almost 58% reduction in mortality related to Clabsi. So again, a group of specialists in this issue have met recently and came up with 10 strategies that are ready to implement all over the world because the evidence is enough. There's enough evidence about these strategies to implement, to prevent, to assure patient safety and improve patient quality. 2 of them are our subjects today. If you look, number 2 is bundles that include checklists to prevent central line infections, and the other one, use of ultrasound guidance for central line placement. So with the evidence is enough, I think we all have a job here to prevent this important preventable cause of mortality. Go back to the guidelines from the Joint Commission and from the CDC. They have emphasized on these 6 main points. They want us, if we're going to implement this issue, is to concentrate in these 6 main points. Number 1 is educating healthcare personnel who insert and maintain catheters. Number 2, use the maximal barriers. Number 3, hand hygiene with skin anti-sepsis of chlorhexidine. Number 4, using ultrasounds. 5, checklist. And then 6, prompt removal of central venous catheter as they are not needed. So I think we can do this. These 6 interventions, we can do this. And our quality improvement project had concentrated on these 6 main objects. In terms of education and training healthcare personnel, we have met with people who really insert central lines. We have met with the Department of Surgery, and we went in details of the best practice guidelines. Same thing with anesthesia. We met with nurse managers about our policy that's coming up and the checklist. We're arranging a meeting with the ICU physicians. Same thing with interventional radiology. And we have released the policy just last week. This policy goes in details about definitions, indications, who can insert CVC, where it should be inserted, the supply issues, the maintenance and removal. It tackles everything in details with the best practice guidelines available. Where you can find these policies in our portal. Under policies and procedures, go to medical committees, and then under VAT. It's there. I encourage everybody who cares about central lines to go over it and educate your staff about it. The number 2 is the hand hygiene and skin cleaning with chlorhexidine. I think this practice is not allowed anymore at KHCC. We have to be careful. We have to have a full drape that covers everything. We have to have covering the whole patients, covering the tray, and we can't allow breaking in maximal barriers. We have the supplies, and I think we're ready to implement that. In terms of hand hygienes, we are all aware of the ABCs of hand hygienes, but for central lines, make sure you do it after putting the cap and the mask on, not before. Maximal barriers mean a head cap, mask, eye protection, if applicable, a sterile gown and gloves. And if you're going to cover the patient, you have to cover the whole patient without exposing any part of it. I know the old CVP kits had provided us with only 1 or 2 towels, one for the tray, small towels, and one with a slit in it. This is not allowed anymore. We have provided the central line kit, we're going to talk about it, that has the full laparotomy drape. So the drape that we use for laparotomy, that has a drape for your tray and 4 drapes for covering the patient completely. No, don't say this is very expensive to insert central lines. This is a very cheap drape. It costs around 12 GDs. So, I think we can, prevent with this addition of 12 GDs a major issues and we can have a major cost. I've noticed that our Portacath, Hickmans, or central lines inserted under fluoro machines, we're not using the fluoro drapes. This is only 15 GDs. So I think it's not allowed anymore to insert any permanent catheter under fluoro without the fluoro machine drape. We're working in getting special drapes for central line insertion that provide you with all anatomic landmark. But in the meantime, we have to use the drapes that we have. Number 3 is the using chlorhexidine skin preparation. Again, it's in details in the policy how you do the skin anti-sepsis with chlorhexidine, and you should always allow it to dry. When I started here, we had the issues that it's not available in the OR all the time, and most of the central lines and anesthesia personnel would really use it, but if it's not there, they won't ask for it. But the OR personnel, they want, or the surgeons, they won't use it because they're not familiar with the best practice guidelines. It's there. I think povidone should be taken out, and we already did take it out from the central line trays. We have this chlorhexidine tray, chlorhexidine solution that's available in the OR, in the interventional radiology, everywhere. So it's not allowed to use chlorhexidine unless the patient has allergy. And we have the swab sticks that has, again, they're very minimal. I know a lot of people don't like to use it, but it's there if you have to look for it. And we're working on getting this 5 ml applicator that would be enough for central line insertion. In terms of using ultrasound, I know our anesthesia colleagues use ultrasound for insertion, but our ICU colleagues, they don't. So I think we should encourage that and to be strict about it. Number 5 is the checklist. We're going to talk about it in detail a little more, but we have a checklist that would come with every central line insertion tray that need to be filled. And finally, the prompt removal of central line as soon as it's not needed. I think the central line need should be addressed on daily basis, during downs. I know our ICU colleagues does that, our BMT colleagues does that, but most of medical and surgical patients, we don't address this issue. It just slips under in our mind in a very busy day. So it's very important to address. Nurse managers, that team members should really alert physician that this patient has a central line. Do we still need it or not? And if not, we have to take it out. Hopefully in VISTA, when VISTA becomes live in an inpatient wards, an alert window should come to the physician who cares about the patient about central line for removal if the patient does not need it. Our theme at King Hussein Cancer Center is multidisciplinary, and I think this is not different, and it's really a multidisciplinary theme. To reduce CLABSI, we have to collaborate all. People who order central line insertion and removal, people who insert central lines, healthcare managers with administration to back up and support us, infection control personnel, people who maintain the VAD committee, and finally patients. We have to educate them about what are the proper way to care about the central lines and have them being their own guard to protect themselves from a major cause of morbidity and mortality. Our goal is to reduce the CLABSI rate to as low as possible. I don't think we have to set a goal to 1 or 2 or 3. If we can achieve 0, let's do it. It's not impossible. Other people have done it, and I think we can do it. And then sustain our very low rate as much as we can. The CDC recommend for facilities these 5 recommendations. Empower staff to stop non-emergent insertions if proper procedures are not identified or followed. Bundle supplies in a kit to ensure all items are readily available for use. Provide a checklist. Ensure sufficient access to hand hygiene. I think we have enough work on this. And provide education on a recurring basis for everybody. This is the policy. In terms of the number 1, empower staff, we had a buy-in from the administration that we are going, when we launch the project in June 1st, we are going to with a zero tolerance policy. We have 2 weeks to start working on that, but according to them, any violation would be strictly handled by the administration. And nurses and anesthesia technicians who witness violation of the above-mentioned requirements should report to VAD and Infectious Control Committee. In terms of bundling supplies, we have a CVP kit that our material managers, Ali Yusuf, had helped us to collect. It should have all the things that we need to insert central lines. Anybody who inserts central lines and finds something that's missing, please let us know so we can add it. It will have also the checklist that need to be filled by the physician and the technicians and the nurses who are observing central lines. We're working on providing a fancier tray. We're having issues with the cost and the supplies, but it's going to be the first time applied in Jordan. King Faisal at Saudi Arabia had the same issues, and they're working on the same project, and they're in the final ways on getting this trays. But I think in the meantime, we'll have to work with what we have, which is the tray, including the full drapes, the full sets, the dressing, the sutures, the saline solutions, the chlorhexidine, everything. And then in terms of the checklist, we have a checklist that needs to be filled by the one who's observing, either a nurse or a technician or anybody who's observing central lines. As you can see, you can go in. It's very easy to fill. It's all the check boxes in terms of type of insertion, site of insertion, catheter type, reason for insertion, skin preparation, whether you use chlorhexidine, bovidine, or alcohol, and why. If we did not use chlorhexidine, why? This is very important. And then before the procedure, did the inserter wash his hand? Did he apply large sterile drapes? Yes, no. And then did he wear gloves, caps, mask, maintain sterile field, and for the fluoro drape, large fluoro drapes. So again, this is a simple, easy use checklist. It's about yes or no, should be filled with every central lines. If you have questions about it, don't hesitate to call anybody from the VAD committee or the infectious control committee. This form should go to the VAD committee or the infectious control committee to track our infections rate. So the Institute of Medicine back in 1999 report a very important report called "To Err is a Human," and they estimated about almost 100,000 of Americans die each year from medical errors. They are preventable medical errors. They followed their reports with another report called "Crossing the Quality Chasm," and in order to have a quality health care, we have to have a health care that is safe, efficient, effective, equitable, patient-centered, and timely. And I think, if we go to our basics as physicians, the first rule is first, do no harm. And I think we have to continue on this thing and have our patient safety as #1 goal for our Dr. Pronovus made it to the Wall Street Journal. Very, very nice interview and very nice quotes I took from him. He said, the main barriers are the lack of collaboration and a culture that is resistant to change. I think we have all to resist this issue deep in us about changing, because change is the only thing that gets us better. In terms of the checklist, he stated that the pilots who neglect the checklist before taking off would not be allowed to fly again. But there has not been that kind of accountability in healthcare. And finally, he says, what is perhaps most concerning is when I ask nurses, if you saw a senior physician not comply with the checklist, would you speak up? Uniformly, the answer is no. Could you imagine any other industry tolerating the violation of an evidence-based standards that kills 31,000 people a year? I think this is very important. I think he made a lot of impacts in patient quality and healthcare, and we have to follow his steps. Very simple intervention, and we can make a difference. I think together we can achieve more. This is one of the great themes in my life. As a teamwork, everybody here, starting from nurses, clerks, cleaning personnel, administration, physicians, we can really reach our goal for better quality. And this is Charles Kettering, a very famous inventor for American industry. He stated the world hates change, but it's the only thing that has brought progress. Again, thank you everybody for being here. Sausan, Dana, Anwar, and Farid and Samir, thank you very much for your help, and thank you very much for it.